cancer. Subsites include the lip, the alveolar ridges, the buccal mucosa, the retromolar trigone, the hard palate, the oral tongue, which is the anterior two-thirds of the tongue, as delineated to what is anterior to the circumvalent papilla, and the floor of mouth. If a patient presents with lower lip numbness, this generally indicates inferior alveolar nerve involvement. Malignant transformation rate of leukoplakia is 20% and erythroplakia is 30%. The extrinsic muscles of the tongue alter the position of the tongue. They are all innervated by the hypoglossal nerve, cranial nerve 12, except for the paladoglossus, which is innervated by the vagus nerve. They include the genioglossus, the hyoglossus, the styloglossus, and the paladoglossus. The intrinsic muscles of the tongue are all innervated by cranial nerve 12, and they alter the shape of the tongue. They include the superior longitudinal muscle, the inferior longitudinal muscle, the transverse muscle, and the vertical muscle. The DeCruz study from NEGM 2015 looked at T1 to 2 N0 oral cavity squamous cells after resection and then randomized patients to either upfront ipsilateral neck dissection versus weight and salvage ipsilateral lymph node dissection if they had recurrence. The overall survival was better in the upfront dissection group, 80% versus 60% with salvage. A subgroup analysis suggested that less than 3 millimeter depth of invasion may not be helpful. From this trial, if the depth of invasion is less than 3 millimeters, then the node positive rate is 6%. If the depth of invasion is greater than 3 millimeters, then the lymph node positivity rate is 17%. In terms of additional workup for oral cavity cancer, do a history and physical, assess symptoms of a non-healing ulcer, pain, bleeding, loose teeth, ill-fitting dentures, halitosis, and a neck mass. Physical exam, pay attention to the tongue mobility, the floor of mouth, and then do a neck exam. They need audiology and a dental workup. Note that there's 15% rate of skip METs to level 4 for oral tongue cancers. Level 4 is not addressed in a supraomohyoid lymph node dissection of levels 1 through 3. Staging, AJCC 8th edition T staging, T1 is less than or equal to 2 centimeters and less than or equal to 5 millimeters depth of invasion. T2 is less than or equal to 2 centimeters and depth of invasion is between 5 to 10 millimeters, or the size is greater than 2 to 4 centimeters and depth of invasion is less than 10 millimeters. One more time, T2 less than or equal to 2 centimeters and depth of invasion 5 to 10 millimeters, or size is 2 to 4 centimeters and depth of invasion less than 10 millimeters. T3 is greater than 4 centimeters of any size and depth of invasion greater than 10 millimeters. T4A, lip, is invasion into the bone, inferior alveolar nerve, floor of mouth, or facial skin. Oral cavity is invasion into the bone, the extrinsic tongue muscles, the maxillary sinus, or the face skin. T4B is masticator space invasion, pterygoid plate invasion, skull base invasion, or carotid encasement. End staging for clinically node. So clinical nodal staging. N1 is a single ipsilateral node less than or equal to 3 centimeters in size, ENE negative. N2A is again a single ipsilateral node but greater than 3 centimeters in size, less than 6 centimeters in size, ENE negative. N2B is multiple ipsilateral nodes less than 6 centimeters, ENE negative. N2C is bilateral or contralateral nodes less than 6 centimeters. N3A is greater than 6 centimeters, ENE negative. N3B is ENE positive. Group this into twos. Think of N1 and N2A as single nodes, N2B and N2C as multiple nodes, N3A or N3B as either big, meaning greater than 6 centimeters, or ENE positive. M1 means distant METs. Pathologic nodal staging is as follows. N1 is a single ipsilateral node less than or equal to 3 centimeters, ENE negative. It's the same as clinical. N2A is where things are different. Single ipsilateral node greater than 3 centimeters, less than 6 centimeters, ENE negative, that's the same. Or, this is the one difference, a single ipsilateral node less than 3 centimeters with extranodal extension. This is only with pathologic staging, not clinical. N2B is multiple ipsilateral nodes less than 6 centimeters, ENE negative, which is the same. N2C is bilateral or contralateral nodes less than 6 centimeters, which is the same. N3A is greater than 6 centimeters, ENE negative. N3B is ENE positive, greater than 3 centimeters. Overall stage, T1, N0 is stage 1. T2, N0 is stage 2. T3 or N1 is stage 3. T4A or N2 is stage 4A. T4B or N3 is stage 4B. And M1 is stage 4C. In terms of management, resectable, you get surgery followed by adjuvant chemo, questionably with radiation. Mainly resectable surgery followed by adjuvant radiation. Neck dissection principles: if the depth of invasion is greater than 4 millimeters, dissect the neck. If it's less than 2 millimeters, there's no neck dissection. If it's between 2 and 4 millimeters, then a surgeon preference. If you have a floor of mouth cancer, anterior tongue, or any structure approaching midline, you dissect bilateral necks. Again, floor of mouth, anterior tongue, or any midline structure. If you have clinically node-positive patient, then you dissect the neck. Oral cavity levels 1 through 3 is usually dissected. Indications for radiation adjuvantly. Remember that the oral cavity subset was a risk factor in the Peters trial. Other indications for adjuvant radiation are T3 or T4, a node greater than 3 centimeters, or multiple nodes that are positive, LVSI, perineural invasion. You can consider adjuvant radiation for a T2 tumor that's node negative or depth of invasion 4 to 5 millimeters. Per in-service exam, you should always consider a neck dissection for at least 3 millimeters depth of invasion. Indications for postoperative chemoradiation are positive margins or positive extracapsular extension. For unresectable cancers, you do definitive chemo plus or definitive radiation plus or minus chemo. T1 to 2, N0 gets definitive radiation alone. External beam radiation alone is 70, 63, 56, and 35 fractions. You can consider a brachy boost or definitive brachy for small cases not near the bone. For stage T3 or T4 or node positive that are unresectable, you get chemoradiation. The chemo regimen is preferred high-dose cisplatin, 100 milligrams per meter squared every 3 weeks. An alternative is carbo-5-FU. An alternative to that is cetuximab, or weekly cisplatin, 40 milligrams per meter squared. Management specifics: oral tongue less than or equal to 2 centimeters, which would be a T1 tumor. If it's lateral, then you get a partial glossectomy, which is less than 1/3 of the tongue is removed. If it's 2 to 5 centimeters and it's a lateral oral tongue, you get a hemiglossectomy. This is 1/3 to 1/2 of the tongue that is removed. If you have a midline oral tongue lesion, you get a total glossectomy. For lip cancer, they prefer surgery unless it involves the commissures, which are the corners of the lip, or it's a superficial lesion that occupies most of the lower lip. In these cases, radiation may be preferred because the surgical cosmetic outcome is quite poor. If you have a T1 or T2 tumor, you don't treat the nodes unless the commissures of the lips are involved, in which case you would cover levels 1B and levels 2 down, to the low risk dose. If you have a T1 to T2 tumor after surgery, you deliver adjuvant radiation if there's perineural invasion, lymphovascular invasion, or positive margins. If you have a T3 or T4 tumor or a node-positive cancer, then you give adjuvant radiation for multiple nodes. LVSI or PNI, positive margins, and extranodal extension. You would add chemo for the last two. If you have an upper lip cancer, consider covering the facial nodes. If you have inferior alveolar nerve involvement, cover through to the mandible in your high-risk CTV. And if there's skin involvement, cover the facial nodes. SIM is as per usual head neck, planning IMRT, either post-op or definitive. Volumes: the first echelon nodes for oral cavity are generally bilaterals level 1B to level 3 and the top of level 4. You can consider ipsilateral nodal radiation only for buccal, retromolar trigone if the ipsilateral neck is clinically negative. You cover level 1A for the floor of mouth, the oral tongue, and the inferior alveolar ridge. Your dose is going to be adjuvant 60 and 54 and 30 fractions. Definitive is 70, 63 and 56 and 35 fractions. Time between surgery and post-op radiation should be 6 weeks. Gingiva, hard palate, and retromolar trigone. No brachytherapy due to the risk of osteoradionecrosis in those areas. Toxicity and follow-up: oral tongue, radiation, and surgery provide equal local control for T1 to T2 tumors that are node negative, 75 to 80%. This is much worse with radiation alone for T3 or T4 tumors. Stage 3 or 4 local control is 60%, overall survival is 70%. Local control T1 to T2 and 0 is greater than 90%. Local control for all others is 70 to 80%. Lip cancers T1 to T2, local control and overall survival are 95%. T3 to T4, local control is 80%.